Hello and welcome to Noon Conferences hosted by MRI Online. In response to changes happening around the world right now and the shutting down of in person events, we have decided to provide free daily noon conferences to all radiologists worldwide. Today, we are joined by Dr. David Bloom. Dr. Bloom is a clinical pediatric radiologist specializing in pediatric oncological and genitourinary imaging at Michigan Medicine, CS Mott Children's Hospital. A reminder that there will be a Q&A session at the end of the lecture, so please use the Q&A feature to ask your questions and we will get to as many as we can before our time is up. That being said, thank you all for joining us today. Dr. Bloom, I'll let you take it from here.
Thank you very much. And I'd like to first thank MRI Online for inviting me today to talk to you about pediatric abdominal tumors, abdominal masses. And I am going to share my screen. Uh, so we're going to talk today about pediatric abdominal masses. And obviously, there is so much that we could cover in 1 hour. I've sort of found a couple of important topics to try and review, as well as to really hone in on some of the ways to think about abdominal mass imaging, especially with regards to the use of MRI in pediatric patients. I do not have any disclosures. So our objectives today will have an introduction to imaging and techniques. We're going to review some of the more common pediatric abdominal tumors, and then outline some of the differential diagnoses. And I'm sprinkled throughout the talk some tips and helpful hints that hopefully will make it a little bit easier for you to really come to a correct diagnosis and really help your referring physicians with pediatric abdominal masses. So the approach. In this modern age of teleradiology and remote interpretation and advanced cross-sectional imaging with CT and MRI, we sometimes lose sight of the plain radiographs and their value to us when taking a look at patients who have abdominal distension or palpable abdominal masses or suspected masses. So I find them always helpful. Oftentimes they will be obtained because we're looking at gas pattern, we're looking at other things that might help to explain the patient's abdominal discomfort and abdominal distension. So you can look for calcifications, you can start to hone in on the location of the abdominal mass based on the radiographs, and then the ancillary findings, and I'll show you some examples. In pediatric imaging, as you are all aware, because of portability, lack of ionizing radiation, and its high spatial resolution in small patients, ultrasound is almost always our next imaging step. Once the ultrasound is done and determines that there is a mass, then the key is, well, are we going to go to CT or MRI? And there's always a conversation that occurs with regards to that, and we're going to go over that a little bit more. So our first tip, the radiograph can be your friend. And so if we take a look at these two images, we see that there's clearly mass effect within the abdomen. And if we take a look at the image on your right, there might be hepatomegaly, maybe perhaps there is a mass. We can start to look for other findings, such as, do we lose any fat planes? For example, the psoas margin, or the retroperitoneal fat planes higher up by the crus of the diaphragm. We can clearly see that there's mass effect and the bowel is pushed over. When the colon especially is pushed over, we often think about retroperitoneal tumors. In this case, this is a patient with a known neuroblastoma at subsequent imaging. If we take a look at this image on the left, on your left, we can clearly see that there's mass effect with the bowel gas displaced far over. And if you really pay close attention, you can actually make a likely diagnosis of what the actual tumor is going to be just on the radiograph. So if you pay careful attention, the first thing that you see is the mass effect, but then you also notice that there are pulmonary nodules and masses present. Knowing what is likely to metastasize to the lungs and what is likely a retroperitoneal mass based on the displacement pattern of the bowel and the loss of the psoas margin, such that it's telling us it's a retroperitoneal tumor, likely renal, likely Wilms tumor, which this turned out to be. Now, if we were to try and cover in 1 hour all the neonatal, infant, and older child abdominal masses, we would be going super fast, speed of light. And as you can see from this list, just for the neonate, many masses are going to be benign. So for example, a multicystic dysplastic kidney for a renal origin or severe hydronephrosis. Many of this is already known by prenatal imaging. There are other renal tumors besides Wilms tumors, which are rare in the neonatal period, but do occur. We're usually thinking more about adrenal, non-renal retroperitoneal in origin, such as neuroblastoma or retroperitoneal teratoma, with neuroblastoma much more common. Again, we can have masses related to the genital tract, such as hydrocolpos or hydrometrocolpos, large ovarian cysts, in utero ovarian torsion with enlarged cystic ovaries. We can have gastrointestinal masses, such as duplication cysts. We're really going to concentrate on the tumors today. As we get to older infants and children, we're talking about things like renal Wilms tumor and other renal tumors that occur in the pediatric population, which we'll discuss. Again, neuroblastoma. But as the child gets older, neuroblastoma becomes a little less likely statistically, although still a common tumor. And then again, the genital tract, the gastrointestinal tract, we can even have pancreatic masses. And so, again, too much to cover in 1 hour, but we're going to try and hit some of the more common lesions that you might encounter. Now, when choosing your imaging, we said you're going to have potentially radiographs, and then you're going to have an ultrasound that tells you that there's a mass present, and it'll tell you potentially organ of origin. It may have already told you about metastatic disease to the liver and adenopathy. So we now need to decide, are we going to go to CT or are we going to go to MRI? Now, we do a lot of MRI imaging because of the ionizing radiation issue with regards to CT. However, there is always checks and balances to this decision. So for example, you might avoid ionizing radiation, but you do need to take the risk with sedation or general anesthesia for MRI, depending on the patient's age and their ability to cooperate. Also, what is the staging for that particular tumor that you suspect based on your ultrasound? And what would be the quickest, most efficient, and most effective way for you to answer all the questions the oncologist needs with regards to staging? So what needs to be identified? What questions are still left to be answered? What about the timing of the exam? If this needs to be done on an urgent basis, say, for example, a patient is dropping their hematocrit from a cystic Wilms tumor that's hemorrhaging, do you wait for MRI or do you go quickly to CT, which is a much faster exam and then therefore safer for the patient? What is the likely diagnosis based on your ultrasound and your clinical history? And again, this may alter your decision. So for example, if you think it's a Wilms tumor, we just showed an example that Wilms tumor does metastasize to the lung. We know that current technology, MRI is not as effective for small pulmonary masses and nodules compared to CT. So if you do an MRI for Wilms tumor, for the abdominal imaging, you then are still going to have to do a CT of the chest to look for pulmonary metastases. Whereas if you did the CT of the chest, abdomen, and pelvis, it would be fast, effective, one-stop shopping. And again, this is going to be important to discuss with your referring physicians, trying to determine what is the most effective way to go. In general, we try and do MRI as much as we can because of the ionizing radiation issue, and especially in follow-up with these patients because they will be getting repetitive exams. Resource availability and how urgent is the exam? And what does the national protocols tell the oncologist that they're going to need for appropriate staging and for inclusion in a particular protocol? Now, as for the MRI protocols, they can vary. They're going to be tailored. We want to make them as short as possible, especially if we're using sedation or anesthesia. Typically, the key components are going to be a T1 weighted image, a T2 fat saturated image. Diffusion weighted imaging has become very helpful recently. And then post-gadolinium T1 fat saturated images. The fat saturation is usually very helpful for really showing you the amount of enhancement a tumor may have. If you need additional vascular sequences, you can do that with dynamic imaging post-contrast or use bright or black blood technique in order to help make that determination. Do you need breath holding? Are respiratory motion issues going to be in play? Most of the time, you can do almost all of your imaging with a 1.5 Tesla magnet. However, there are some advantages to using 3T. Contrast choices. There's debates about safety with regards to the potential for NSF and using either linear or macrocyclic agents. Sometimes for the liver tumors, we even use hepatobiliary agents, such as gadoxetate. Now, the timing of the sedation and anesthesia may need to be coordinated with other imaging needs. So, for example, the patient may also need a PET CT, or they may be having an operative intervention or an interventional radiology procedure that needs to be coordinated so that they're under one anesthesia or sedation. So again, there's no right answer to say it's always MRI or it's always CT. There are certain things that you have to balance and think about. So let's start with some of the more common tumors we do see. And this talk would be incomplete without a good discussion about neuroblastoma. So neuroblastoma is a common solid neoplasm in children. In terms of a likelihood of type of tumor that pediatric patients get, it's number 3 overall behind leukemia and CNS tumors. The median age is about 2 years. Most cases are usually diagnosed by the age of 5. Neuroblastoma arises from sympathetic chain or adrenal medulla, neural crest-derived tumor. And a simple 2/3 rule is that 2/3 of neuroblastoma will arise in the abdomen, and of those, 2/3 will arise in the adrenal region. They can also occur in other locations along the sympathetic chain, especially in the region of the organ of Zuckerkandl at the hypogastric plexus. Neuroblastoma does metastasize. It goes to bone, and that's specifically cortical bone marrow, and we're going to talk about that difference, liver, lymph nodes, and then there are skin manifestations. Sometimes patients will present with the blueberry muffin appearance. Staging. There have been several revisions to the staging that is used for neuroblastoma, and I'm going to show you one of the more current ones that is used. In the past, we used the Evans staging system, and I will point out that metastatic disease in general was stage 4. There was a subtype, which we are going to talk about, called 4S, where you had a primary tumor that was more like stage 1 or 2, and there were metastases to the liver or the skin or the bone marrow, not the cortical bone, and we'll talk about that difference. And those patients were less than a year of age. In that case, 4S, in many cases, had a better prognosis than stage 4 disease. It had a different biological behavior, which we still don't fully understand, but we do know it still occurs under the new staging system. Unfortunately for neuroblastoma, in terms of prognosis, about 50% of patients are usually in a more advanced stage at the time of their initial diagnosis. Now, I've referenced a great INRG task force report from 2009, and this discusses the new staging system. And as you can see, it's localized disease, or L, M for metastatic disease, and the 4S in the old system is now MS, under 18 months of age. And again, you can have skin lesions, liver lesions, or bone marrow metastases, and we'll talk about that. And that's the key point. It's bone marrow, not cortical bone. And basically, what does that mean? That if you have radiographs that show metastatic disease, that there is periosteal reaction, bony destruction, metaphyseal lucent bands, then that's considered stage M, not MS, regardless of the age and the other findings. The radiographs and the CT and the bone scan should be normal. It would be an MIBG scan that would show you the marrow disease or a marrow biopsy. The other thing that's been added to the new system is what's called IDRFs, or image-defined risk factors. And you can see them listed here. And basically what they talk about is mass effect, vascular encasement, vascular invasion, other invasion of adjacent organs. So for example, if you invade the diaphragm, and we recently had a case like that. So again, you look for these imaging-defined risk factors, and those risk factors portend towards the ultimate staging as well as the treatment protocols. So you need to look for all these things, and there's some great review papers that talk about that. Now, for the imaging, if you do have radiographs, about half of neuroblastoma will demonstrate some calcification. May be hard to see, but if you see calcifications, you're much more likely dealing with neuroblastoma than Wilms tumor. They're right off the bat by statistics. Ultrasound, as we said, is usually the first step. We favor MRI because neuroblastoma, neural crest-derived tumors, neurogenic tumors like to be paraspinal and go into the spinal canal. And that's a great way to look for that is with MRI. And then again, our molecular imaging, nuclear medicine workhorse is going to be MIBG, although there's also PET and PET-CT imaging that is done. So for example, we look at this radiograph, and I already see a couple of things that make me concerned. Number one would be that calcification in the left upper quadrant. I can see sort of clump-like calcification. The other thing is the appearance of the bony structures. If you look at the iliac wings and the proximal femurs, and even the ischia, we are very patchy and mottled. There are some lucent areas that are concerning for bony metastatic disease. We may even have some loss of height of this vertebral body. We further look at this patient, and on a sagittal left upper quadrant ultrasound, we can see the splenic tip and a large suprarenal mass with associated echogenicity centrally that represents the calcifications. A little bit of shadowing here. On this patient's MRI, we can see that there's a suprarenal mass, heterogeneous on T1, mostly isointense to muscle, but with some bright foci related to hemorrhage or mineralization. Heterogeneous enhancement above the kidney with mass effect, and MRI is beautiful not only to show you the spinal canal, you'll see that, but also for metastatic lesions throughout the visible skeleton. As I would point out in this slightly older child, the marrow even on T1 should not be so dark uniformly. There should be more fatty marrow. So as you learn marrow maturation processes with age, you'll be able to quickly recognize that this marrow is diffusely abnormal. You see more focal enhancing rim-like metastatic lesions, but actually almost all of the marrow spaces are involved. And in the same patient, we can see this suprarenal mass effect on the kidney. And I want to point out how it is encasing, as we talked about with the IDRFs, the left renal artery. There is mass effect on other structures. And again, you get a beautiful look at the spinal canal. So tip number 2, I love paraspinal lines. I think that this is a great thing. So when you have a patient who they suspect maybe has a mass, or you're even just reading the chest radiographs for another reason, I always like to look at my mediastinal lines, which I'm sure you've learned about in other lectures. If we look very carefully here, we have the right heart border, but we have additional densities that we can see right paraspinal. There's also some fullness in the upper abdomen. It would be hard to call on a radiograph, but I will point that out. So if we look very carefully, we have this line, and we also have this line. And you'll see another example coming up. Neuroblastoma can be within the chest, can be thoracoabdominal, can be within the abdomen. I've seen many cases where it likes to crawl and move retrocrural and then up into the middle and posterior mediastinum, paraspinal in location. On the ultrasound of this patient, we can actually see the aorta encased by tumor. Here's the spine, left lobe liver, right lobe liver, and this is all retrocrural tumor. This is actually all retrocrural tumor with some calcification extending up into the posterior mediastinum. Now we look at it at MRI, and we can see how the crus is elevated, so we understand why that paraspinal line is abnormal, and we clearly see tumor extending into the neural foramen and into the spinal canal. So if we use our tip, we take a look at this and we say, well, there's just a lot of fullness in the abdomen, but what's this? I don't like this. You know, that's not a normal paraspinal line for just the descending thoracic aorta coming to the thoracoabdominal aorta. If we look very carefully, we also have a little bit of calcification. And again, we have a very large retroperitoneal mass. We see not only encasement, the elevation of the aorta off of the spine, encasement of the renal artery, the right renal artery, mass effect on the kidney such that there is an obstructed nephrogram compared to the normal left kidney. We see how we cross midline, and as that tumor extended superiorly, that's what gave us that widened left paraspinal line from retrocrural metastatic adenopathy or extension of tumor directly. I will point out that neuroblastoma can present with hypertension, and you can imagine why, based on the sort of created renal artery stenosis and or a paraneoplastic process from the tumor itself. So here's the next tip: encasement of vessels. If you see elevation of the aorta off the spine and encasement of the aorta and other great vessels, then think about neuroblastoma. It likes to do that. Lymphoma is on that same differential, and you'll see examples later on. Same is true with rhabdomyosarcoma and germ cell tumors. But in terms of if we see this, what are the ones that are going to be more common in the abdomen? We're really going to think about these two, and in the right age group, neuroblastoma. Another patient who has a large suprarenal mass on the left already has metastatic disease based on the T2 weighted MRI, and we can see the encasement of the celiac trunk. We see encasement of the descending thoracic aorta. Abdominal aorta. And again, this large abdominal mass. Again, encasement of the aorta, not as elevated, but encasement of some of the branch vessels such as the SMA. Now, I had mentioned to you that previous stage 4S or stage MS in the current system, neuroblastoma. This patient looks quite abnormal, right? Now, this patient is under a year of age. They have extensive metastatic disease throughout their liver. Look at the multiple metastatic lesions throughout. Here's inferior right lobe. And they have a primary retroperitoneal tumor with some encasement of the supramesenteric artery. So when we take a look at this patient, and a lot of mass effect elsewhere too, we would say this looks terrible. But again, MS does potentially have a better prognosis, but you need to complete the evaluation. So do they have skin lesions? That's still okay for MS staging. But this is a different patient. But if they had this bone scan, they could no longer be MS. Because on this bone scan, we see extensive metastatic disease. We see it in the proximal femurs. We see it throughout the spine, in the ribs. We see it for the calvarium. And in this particular patient, not germane to this talk, but they actually had involvement of the skull with extension of tumor into the subcutaneous tissues and had a palpable mass. So again, we would look at this bone scan, this MDP bone scan, and say very abnormal. We can actually see uptake by the primary tumor. Now, in general, in younger children, looking for metastatic disease, especially in neuroblastoma, can be difficult on bone scintigraphy because the metaphyses and the physes are quite active and therefore have significant uptake of radiotracer. The issue is how much is too much, and can you truly tell? And it takes some experience as to whether or not there's metastatic disease within the ends of the long bones. And metaphyseal metastatic disease, that's not uncommon. That's a good place for metastatic disease to set up shop. So in this case, if our MS patient had this bone scan, they would no longer be MS, but be M. However, if their bone scan was normal and they had just an MIBG scan, meta-iodobenzylguanidine, a norepinephrine analog that is used for imaging with typically iodine-123, then you would say that this could still potentially fit. There is discussion about how much marrow involvement is too much, and then you have to treat them more as stage M versus MS. But again, we can see the bony involvement. We shouldn't have this kind of uptake on MIBG, topic for another day. But again, for MS disease, you can have MIBG scan positive, but you should have bone scan negative if you've done both. So let's move on to Wilms tumor. It's the most common solid mass that we see in childhood. As the children get a little bit older, the peak's a little bit older than for neuroblastoma, and they can present with hematuria, high blood pressure. Especially, they will present with significant symptoms out of proportion to potential minor trauma. That happens with a lot of renal lesions, as a matter of fact. About 1% of cases are familial. And we do know that there are some associations that we do a lot of screening ultrasound for. So patients who have diagnosed congenital hemihypertrophy or Beckwith-Wiedemann syndrome, we will do routine ultrasound screening looking for the potential of Wilms tumor, as well as some other tumors as well, but especially Wilms tumor. Aniridia with a particular deletion is another risk factor. Now, in that case, this is not familial aniridia, but typically sporadic aniridia. And the aniridia is part of the mnemonic for Wager syndrome. Dennis-Drash syndrome, there are some associations with Klippel-Trenaunay and neurofibromatosis, but the ones I want you to remember are If you know the patient has these three, that's an important association for Wilms tumor. And I'm sure with advancements in our genetic understanding of disease, we may even find more. If it's bilateral, synchronous, that's technically stage 5 Wilms tumor that usually occurs in much younger patients and will have underlying problems with either nephroblastoma or at least nephrogenic rests. Now, Wilms tumor staging, as I said, it's a more typical staging, except for stage 5, which is bilateral synchronous Wilms. On imaging, we said that you can have calcification, but you usually don't see it on radiograph. It's very subtle, and it's not that common. What we are looking for is vascular thrombosis. I should have put this in a highlight because that's such an important part of the evaluation of Wilms tumor. And then we do know that up to a fifth to a quarter of patients will have pulmonary metastases. So there is a debate about MRI or CT because CT is so great for the pulmonary metastases. Should you just continue and do the imaging of the abdomen and pelvis as well for staging, or go on to MRI? Again, it depends on the situation. If I have an old enough patient who can cooperate with MRI without sedation, I would potentially do CT of the chest and then just move them over to the MRI suite and perform an MRI of the abdomen and pelvis. So here's a CT of a large Wilms tumor. As you can see, this tumor, instead of encasing the aorta, is displacing it and the IVC over to the right. We also see a little bit of enhancing renal parenchyma. We look for this claw sign to tell us that this was a renal mass that has broken out into the retroperitoneum. Regional adenopathy can be seen. This is the MRI of this patient. Okay, we can also look for liver metastases, and again, CT for pulmonary metastases. Another patient with a very large Wilms tumor, and again, we can see that claw. We can look at the liver. Typically, Wilms tumor does not go to bone, so the MRI doesn't give you necessarily that advantage. If you do see bone lesions, you start to think about another diagnosis. And you can pick up larger lesions, but not necessarily the smaller ones. This patient, which I had quite some time ago, has a very nice ultrasound example of one of the problems with Wilms tumor, which is it likes to have vascular invasion. If we look down to the CT, we can see the claw sign and the large heterogeneous mass on CT for this Wilms tumor, and we can actually see tumor thrombus extending in the left renal vein over to the IVC. In this particular patient, a different patient, this is a sagittal image. Here is the right hemidiaphragm, hepatic vein, liver. We can see the right atrium a little bit. This is the IVC completely filled with tumor thrombus extending all the way up into the right atrium. In this particular case, here's the aorta on a transverse image. This is the IVC. And actually that lit up with color Doppler, that is neovascularity of the tumor thrombus going up into the IVC. That's one of the ways that you can try and tell the difference between bland thrombus versus tumor thrombus, is if there is actually blood flow within the thrombus that you see. On this MRI, a Wilms tumor on the left renal vein extending up the IVC. As I mentioned, stage 5 Wilms tumor will show you bilateral renal masses. And so we have that in this particular patient. You do have to wonder about underlying nephrogenic rests, precursors to Wilms tumor, and also certain genetic predispositions that might lead to bilateral Wilms. Again, you can look at the liver, but liver metastases are not that common in classic Wilms tumor as compared to lung metastases, which you can pick up larger lesions on MRI within the lung bases. Again, the marrow spaces are usually normal. Again, the important part is to make sure that you look for the multiplicity, the extent of the lesion. You're descriptive in terms of its enhancement pattern, and it enhances heterogeneously. Wilms can be quite cystic as well. And you're especially looking for that vascular invasion like I showed you. Another entity that you can uncover on occasion is the either focal nephroblastoma or in this case, diffuse nephroblastoma. So we actually have a T1 weighted image here and a post-gadolinium T1 weightage here. It was not done with fat saturation, but we can see that all these lesions are enhancing. and they are peripheral in location with some centrally spared renal parenchyma, bilateral nephromegaly in this very young patient, and this is diffuse nephroblastoma. Were you to biopsy these, they would be precursors to Wilms tumor. They would be large nephrogenic rests, and you have to follow these patients very carefully because any of these can turn into Wilms tumor. Now, what about other renal neoplasms we might see? I mentioned if you have a renal mass and you think you see bone lesions, that's not a common occurrence for Wilms tumor. Anaplastic Wilms tumor, very aggressive Wilms tumors, not the classic triphasic Wilms tumor, can do a lot of very unusual things. But if I see bone lesions, I start to think about what we used to call many years ago Wilms variants, now separated out as other tumors, including the one that likes to go to bone, or can, called clear cell sarcoma of the kidney. Its imaging is going to be very similar to what a Wilms tumor would do, but again, the bone metastases does favor that diagnosis. At other times, you only will know at the time of pathology. The rhabdoid tumor of the kidney is much younger patients. It's a very aggressive tumor. It's almost in the same family as atypical teratoid rhabdoid tumor. And their hallmark is that you can have brain lesions, especially posterior fossa. And there is some debate about whether or not it is a second primary of rhabdoid tumor or an ATRT type lesion versus metastatic lesion from the primary in the kidney. We do see renal cell carcinoma. It's rare. It's older children, but we do see it on occasion. There's a rare entity called renal medullary carcinoma, which I do want to point out, because if you're working at a larger center with sickle cell patients, this is one that they are at in risk for, although it's still a very rare diagnosis. So especially in sickle cell trait. I've also seen it in sickle cell heterozygote SC disease. And then finally, you can uncover renal lymphomas and leukemias. Now, this is a CT example. I do not have an MRI example of renal medullary carcinoma in a patient with sickle cell trait. And I would like to thank the Society for Pediatric Radiology for this image. So we see a renal mass, and we also see extensive adenopathy. Now, we could add renal medullary carcinoma, another very aggressive tumor, to the encasement of the aorta category. Although it's such a rare tumor, I don't usually include it on my list. But again, this is renal medullary carcinoma. Very aggressive, very poor prognosis. And this patient was a very interesting patient who had had multiple surgeries for scoliosis and had developed what was believed to be osteomyelitis of the hardware and the spine, and had the hardware removed. And you can see postoperative changes as well as abnormal soft tissue. But what we also uncovered at the time were bilateral renal masses when we were doing their spine imaging, which this would be very similar to what we would do for abdominal imaging with MRI for tumor. And these bilateral renal masses turned out to be Burkitt lymphoma. So again, lymphoma can give you multiple masses. Turning to liver tumors. Liver tumors are there's going to be some overlap with many of the tumors with regards to how they image. And it's a different discussion that we would have with regards to whether or not you would use a hepatobiliary agent, gadolinium hepatobiliary agent, as compared to more traditional gadolinium contrast. And again, that would be a topic for another time, but they do have a lot of overlap. There's certain ones that I do want to point out, though, that might be helpful to you. And one of the things with liver tumors is that the age is very helpful. So there's certain tumors that you typically see in the very young, as you can see listed in this chart. And when we get to be in the teenage years, we start to think about other tumors as well. And so knowing the patient's age can be very, very helpful. Again, an image that I borrowed from Radiographics and Dr. Chung from their excellent article as referenced below. You can see in mesenchymal hamartoma in a very young patient, here they've done MRI. The asterisks are showing you normal liver, and we have a very bright T2 weighted image within the liver that has multiple septations and cystic spaces. On a contrast enhanced image, the septations would enhance, the cystic components would not. We recently had a patient that had CT imaging that showed a very, very similar like lesion. Cystic with septal enhancement, thin imperceptible wall, and you can tell it's a very, very young child, just several months old. And this was a mesenchymal hamartoma at pathologic diagnosis. So again, cystic, they can be solid, but cystic and young patient, very little solid enhancing components. These are all the things that you want to think about with mesenchymal hamartoma as a potential liver lesion. The next one I want to talk about is hemangioma and hemangioendothelioma. Those are hard to differentiate routinely by imaging, but we're mostly talking about the infantile hemangioma. So it's a benign endothelial proliferation. It can lead to a lot of shunting. It's a very vascular neoplasm. Patients can present with congestive heart failure. As a matter of fact, as a pediatrician, if you were seeing a patient and they were in congestive failure, you would listen over the heart for a potential shunt. You would listen to the lungs. You would listen to the anterior fontanelle, listening for a potential vena Galen malformation, which can lead to shunting and congestive heart failure. But you would also listen over the liver, looking for the potential of a bruit and potential liver lesions such as hemangioma or a large hemangioendothelioma. It proliferates and then involutes. You can have anemia and jaundice. There is an association with hypothyroidism as well. And then there is a particular syndrome called the Kasabach-Merritt syndrome, where you can have loss of platelets, consumptive coagulopathy. The treatment currently is at times just observation, depending on the clinical scenario, because they should involute. Or alternatively, medications such as propranolol, a beta blocker, or steroids. These can be embolized as well since they are highly vascular. So in this particular patient, we see the bowel is displaced inferiorly. We have either a large mass or hepatomegaly. Heart is a little bit big. We do not have gross congestive heart failure, however. When we do an ultrasound of the abdomen, we see multiple hypoechoic lesions that are quite vascular, flow within them, flow around them. There's a lot of vascularity to this liver that we would not typically see on color Doppler. And again, look at the lesions and the size of the liver compared to the kidney. This is the right kidney. We do MRI. These lesions are typically hypointense on T1, hyperintense on T2, and this is another T2 weighted image. And again, they should show enhancement because of their vascularity. And again, we can see the hepatomegaly. And this particular patient had multiple hemangiomas. So the next tip, if you see multiple liver masses in the neonate or young infant, this is the list that I want you to think about. So you want to take a look at that vascularity. I'm going to talk about that with another tip coming up. To think about hemangioma or hemangioendothelioma. Metastatic neuroblastoma, I already showed you multiple liver lesions. They can be large, they can be small, variable in size. And then there's also multifocal hepatoblastoma. Now, typically hepatoblastoma is not multifocal. That's not the routine presentation, so you would put that lower on your list. And again, if the patient is acting infected, then potentially multiple abscesses. And abscesses can occur in association in the neonate, for example, with umbilical venous catheters. So the next tip, the tapering of the aorta with shunting. In the patients who have multiple hemangiomas within the liver, there's a lot of shunting. Look at, for example, on this CT, here's a large giant hemangioma within the liver in this neonate. Again, another borrowed image. And we can see the size of the hepatic artery, the proper hepatic artery and the celiac trunk with the takeoff of the splenic artery because of all this shunting. And look at the neovascularity. The proper hepatic artery is almost the same size as the aorta. In this same patient, we look down, we can see how it's starting to taper. Even the celiac trunk is much bigger than the supramesenteric artery. And again, the blush of that hemangioma. Again, you can see the same thing on Doppler with very fast, low resistance flow. Again, the resistive index here is only 0.5. And again, we can see the tapering of the aorta after the takeoff of the celiac trunk, which is where the shunting will occur for the AV shunting of hemangiomas and hemangioendotheliomas. So look for that. That can be a helpful sign, that vascularity. Hepatoblastoma, the other lesion that you would be thinking about, is typically not as vascular as that. So that can be helpful, especially if you have one large giant hemangioma. The other thing that will help will also be clinical scenario. So are there risk factors? What is the alpha fetoprotein level? Those kinds of things. So in hepatoblastoma, we said those are young patients. That was on our original chart. More common in boys. And the risk factors, I've listed several here. It also is congenital hemihypertrophy and Beckwith-Wiedemann. So we already mentioned before that we do screening with ultrasound for tumors in those patients. That would also include hepatoblastoma. FAP is another one. And then I want to point out that prematurity, especially in very low birth weight infants, there is an association, not 100% sure why, with hepatoblastoma. The easy answer to this, if it ever shows up on the test, it's more commonly found in the right lobe liver, and that's because the right lobe is bigger. There are different subtypes of hepatoblastoma with prognostic implications. Again, you need to look for an elevated alpha fetoprotein. And in the same vein as with Wilms tumor, hepatoblastoma does metastasize to the lungs. And you really do need to know about pulmonary nodules. And so therefore, do you do the CT, chest, abdomen, pelvis all in one stop, or do you move on to MRI? And it varies. Again, it depends on a lot of the factors that we talked about. Ultrasound is still going to tell you that its organ of origin is the liver, and then you can start working the patient up from there. You do need to take out everything in order to have a potential cure. I don't want to spend a lot of time. We could spend a lot of time talking about hepatoblastoma and the new way that we use to really try and stage the hepatoblastoma at the time of diagnosis. There's something called a pretext classification, which I haven't mentioned here, but I think is an important thing to look up if you do have a patient with hepatoblastoma. So a large liver mass, potentially some calcifications here, not vascular like we saw with the giant hemangioma. And again, it's very heterogeneous on T2, and it has heterogeneous enhancement. Here it has almost the appearance of a central type scar, and it can. So the central scar is not unique to just FNH or fibrolamellar variant of HCC. And again, look at the age of the patient. You can tell just by looking at the MRI. Here's another one that has a bit more of a central scar appearance to it. Very innocuous looking, very exophytic off of the right lobe liver. Another patient with hepatoblastoma. How about hepatocellular carcinoma for liver lesions? Well, in most cases, it will be chronic liver disease. So we do a lot of screening. For patients for HCC if they have underlying chronic liver disease, which includes Fontan hepatopathy. I haven't listed that here as well, but that's become much more of a common occurrence, especially in our cardiac patients who have undergone Fontan procedures. You do look for an elevated alpha fetoprotein. There is this teenager fibrolamellar variant. It doesn't have to be a teenager. Classically, it's older children. No association with chronic liver disease. And they will have a central scar mimicking other lesions as well. So again, that is the fibrolamellar variant is a harder diagnosis to make. Most of the time we're doing screening in the chronic liver disease patients. And the ones that we most commonly see would be cirrhosis for various reasons, which would include patients who have had prior Kasai procedure for biliary atresia or neonatal hepatitis. We do see occasionally glycogen storage disease patients, and I've seen one or two patients with tyrosinemia as well. This is an example of a fibrolamellar variant of HCC. Again, a very large heterogeneous mass within the right lobe liver. We can see its relationship to the vessels, and that becomes important in the hepatoblastoma patients. If this were a hepatoblastoma, looking at various factors for that pretext and post-text classifications, and there are very good papers on that if you're interested. And again, this shows us heterogeneous enhancement, maybe the attempt of some type of a central scar. You'd want to look for early enhancement of the central scar. Let's move on to rhabdomyosarcoma. So in rhabdomyosarcoma, the three locations it likes to occur in the pediatric population are head and neck, genitourinary, and the extremities. So again, it's another one of the sarcomas of the extremities where we would be looking for lung metastases, typically with CT. But again, it can occur in the abdomen as well. The classic locations are in the urinary bladder, the vagina, and in the prostate. Rhabdomyosarcoma can occur anywhere else in the abdomen and has a predilection for peritoneal spread of tumor as well. And we'll talk a little bit about that. But again, these are the three major sites in the abdomen that we do think about. So you think about rhabdomyosarcoma if you see a bladder mass, or if you think there's a mass arising from the prostate, or in the case of the vagina, you can have something called sarcoma botryoides, that cluster of grape appearance to the mass that is visible on exam. Rhabdomyosarcoma can also occur in the biliary tree, and its classic metastatic pattern is to the lungs and to the bone. So the next tip, look at the rectal gas pattern. Now, in this particular patient, we really don't see much rectal gas. We do see what looks like maybe a distended urinary bladder, but not much rectal gas. And I also try and take a look at the obturator internus fat planes as well. I have seen several cases of bladder and prostatic rhabdomyosarcoma. I've also seen a case of prostatic lymphoma where the rectal gas is displaced off to one side. So I always like to make sure that if I see the rectal gas, that it's nice and midline and the fat planes look symmetric to me, as best as I can tell. That's a quick look to see if someone has the potential for a pelvic mass. But again, if the rectal gas is off to one side or the other, and I've seen that in the case of vaginal rhabdomyosarcoma, where it was clearly evident on the radiograph, and then when the physical exam was finally completed, we found out there was a protruding mass from the vagina. So use that clue. And this patient is constipated, was having signs of obstipation as well, was having straining and difficulty and pain with going to the bathroom. So we did an ultrasound. This is the urinary bladder, sagittal, head, and feet, and we can see this large heterogeneous mass pushing on the gas-filled rectum. The spine would be back here. And again, we can understand why the rectal gas would be displaced or effaced. Urinary bladder, the large mass, the rectum is displaced over to the right. And again, we can see how this is a very necrotic tumor. This was a prostatic rhabdomyosarcoma. Another patient with a prostatic rhabdomyosarcoma, they have cystic change with hemorrhage into the mass. This is the Foley catheter, which is encased and displaced by the mass, which makes sense considering it's prostatic in origin. And we already can see that there are bone lesions consistent with bony metastatic disease. Also, metastatic adenopathy within the right iliac chain. So another tip, omental caking or peritoneal seeding of tumor. So for example, on this CT, I did not have an example on MRI, but you would look for the same thing of enhancing tumor. And I will give you another little tip off of this, but this is all tumor. And we can see the thick nodular enhancement of the peritoneum next to the right kidney and a little bit along here and along the falciform ligament and throughout the mesentery. And so this omental caking or peritoneal seeding, this peritoneal carcinomatosis in essence, the differential diagnosis that we think about is rhabdomyosarcoma, Burkitt-type lymphoma especially, and any lymphoma, and then ovarian neoplasms as well, which we're going to leave for another day. So let's finish up with lymphoma, okay? Multiple presentations. I'm sure everybody's very familiar about mediastinal masses and adenopathy. I will talk about a couple of things that we do think about with lymphoma, especially the vessel encasement and the potential for it being the pathologic lead point of an ileocolic intussusception. It also could be other types of intussusception, including colocolic. So borrowed images to show you an intussusception related to Burkitt lymphoma. We can see tumor within the liver, multiple masses within the left kidney, also within the right kidney, barely visible. This is a different patient. The encasement of the vessels, look at the celiac trunk, proper hepatic, and the splenic artery, all encased by tumor. And here we have bilateral ovarian involvement and peritoneal seeding and omental caking. And these were all cases of Burkitt lymphoma. In this particular patient, I think that many people are aware of the fact that it can involve the bowel. I've seen it involve the rectum with a very similar appearance. I did not have an MRI example. In this example from Dr. Chung, we can see that the bowel wall is thick and the bowel loop itself is aneurysmal. And we can see a air fluid level within the bowel, and it's pointing to the very thick abnormal loop of bowel. So when you see that aneurysmal change and bowel wall thickening, one of the things to think about, and almost always to think about in pediatrics, is lymphoma and lymphoma involvement of bowel. So what are the takeaways from what we talked about today? So the first thing is think common tumors first. So we know that the most common ones we see are neuroblastoma and Wilms tumor. We mentioned a couple of other things, including lymphoma in the slightly older patients. If you see encasement of vessels and elevation of vessels like the aorta off of the spine, think about neuroblastoma. Lymphoma and rhabdomyosarcoma can also do that. If it's going into the neural foramina or the spinal canal, neurogenic tumors and neuroblastoma until proven otherwise. We didn't go into the neuroblastoma to ganglioneuroma spectrum. There's ganglioneuroblastoma and ganglioneuroma, and those are just more mature neurogenic tumors, but I wanted to concentrate mostly on neuroblastoma. If you see bilateral renal involvement, it can be bilateral Wilms, so you have to think about that, but leukemia and lymphoma can do it as well. Lymphoma, if you see intussusception out of the normal typical age range for ileocolic intussusception, and ultrasound shows you a potential mass as a pathologic lead point, think about Burkitt type lymphoma. I've seen this now maybe about a half dozen times in my career as the presentation of their Burkitt lymphoma. And then liver tumors, the age is important. Use that vascularity like we talked about for hemangioma, giant hemangioma. Obviously, if it's multiple lesions, you'll even more likely favor the potential of hemangioma. And then remember that rhabdomyosarcoma likes to go to 3 specific places: to the head and neck, which we weren't going to talk about today, but genitourinary is very important. And again, it can also be in the extremities, one of its more typical presentations. And I think that's everything. So what I'm going to do is I'm going to now go to the Q&A. And so I'm going to try and answer those questions, and I hope everybody can hear me. So Alan asked, what is the most common presentation of large B-cell lymphoma in children? My experience, I don't know the textbook answer. My experience has been mostly for mediastinal mass and lymphoblastic lymphoma, especially one of the more typical presentations would be with pericardial and pleural effusion associated with that mediastinal mass. That's what I have seen. And at what age, Alan also asked, at what age do you stop screening for Beckwith-Wiedemann? That's an interesting question. There's not great literature about when you stop. There's not even a lot of consensus when you look at the literature about when to lengthen your screening. So if a child is born and a diagnosis of Beckwith-Wiedemann is made, they're screened every 3 months with ultrasound, usually up till about 3 to 5 years of age. Then it goes to every 6 months. But I've seen some doctors continue with every 3 months up to teenage. And then I've seen people usually stop at age 10. I've seen other people go up to age 15. I'd have to go back and look at the more common cutoff points in the more recent literature, but usually the screening stops as you start to get into the teenage years, although we still have some teenagers that we follow. So there's not a perfect answer there in terms of what the referring physicians are doing. Okay, let me see if there's anything else I can. What's our protocol for follow-up of nephrogenic rests? I happen to like MRI, and we usually do renal mass protocol MRI. And the reason is that the signal intensity might be able to tell you a little bit about whether or not it is hyperplastic or fibrotic, which might give you a little bit more information. In general, any imaging should be fine because it's really going to be about size change and aggressiveness of any rest you do see as to whether or not you're going to start to worry about the potential of a Wilms tumor. So if it starts to rapidly enlarge, if it starts to become more cystic, if you see any new adenopathy, then obviously you start to get more concerned that it's a developing Wilms. And the surgeons are usually pretty quick, and the oncologists are pretty quick to to do something about that lesion before it becomes too big. Because as it continues to enlarge, think about it, if you have nephrogenic rests, you are going to typically be multiple and bilateral. You would like to do renal sparing surgery. So it becomes harder the larger the mass becomes. So as soon as you start to have any type of concern, you usually pretty quickly go to either biopsy or mass resection or partial nephrectomy. But I do like MRI. I think because it is not only a vascular phase agent, but a tissue phase agent, you can usually get some very nice imaging and really pick up the lesions and make them a little more conspicuous with MRI. You're not beholden to the timing of the bolus just with CT, depending on you catch it in the nephrographic versus the corticomedullary phase. So it really depends. Now, again, timing with bolus tracking and so forth makes that easier, but sometimes it doesn't work out perfectly. Cystic partially differentiated nephroblastoma, do you use the same staging as Wilms tumor? That's a great question. I actually don't know the answer to that. We have not had in several years a CPDN. So I don't know the answer to that. I would think that we would probably use the same staging system, but since it's felt to be sort of in between a cystic nephroma and a Wilms tumor as well, it's less likely to give you metastatic disease, but you still would look for regional adenopathy as well as part of your abdominal imaging. Let's see here. Do you use hepatic MRI contrast in differentiating liver lesions at any pediatric age? Can we apply LIRAD in pediatric HCC? So two great questions. Number one, we do use gadoxetate and liver tumor imaging. We especially use it in our screening of our chronic liver disease patients, such as the Fontan patients and other patients with history of primary sclerosing cholangitis or other related liver issues. So we do use it. We will use it in almost any age group. We don't typically use it under a year of age, but it can be used, and we have not had the problem with the respiratory distress that some people have talked about with using some of these hepatobiliary agents. So we do use it. It's not usually the contrast of choice at initial tumor imaging. We'll usually stick with a more typical gadolinium agent because you can do wonderful things with that. And especially if you're using multi-Hance, you would have the ability to capture some of the hepatobiliary phase as well if you needed to, as compared to doing, for example, MRCP as part of your liver tumor protocol as well. And we could talk about that another time. Can you apply LIRADs? People have tried to look at this. I would refer to you to several articles from Jonathan Dillman and from Andrew Trout from Cincinnati Children's regarding that concept. You can technically apply LIRADs in the teenager group, but it's not routinely used by pediatric radiologists, is my understanding. Let's see if there's any other questions. Okay. Which pediatric abdominal peritoneal seeding do you see more commonly? The one that we see most commonly, I would think, is probably rhabdomyosarcoma. I have seen a couple of cases where lymphoma has done that as well. I would like to point out, I didn't mention this earlier, I think diffusion weighted imaging is a great tool for this. And that's why we always do it as part of our abdominal tumor imaging. And most of our abdominal protocols include it typically. And the reason is that it will show you areas of restricted diffusion from subtle tumor seeding that you might not otherwise pick up on your T1 and T2 weighted images as you're doing your routine scrolling and evaluation. And so I see some areas that pop up, and then I can go back and take a look to see if there is any subtle enhancement or nodularity that might be concerning for peritoneal seeding. We had a boy who had an extrarenal Wilms tumor who had a recurrence that was very, very subtle that my partner expertly picked up by using the diffusion weighted imaging first and then going back to be able to find the subtle seeding. What are the sequences you must do when imaging neuroblastoma and Wilms in MRI? Do you use the full routine abdomen MRI sequences, which can take a very long time, and would you follow them with MRI? So We typically will do, as I mentioned on some of the earlier slides, just a T1, a T2 fat saturated, and post-GAD fat saturated T1 weighted imaging, usually in 2 planes. I don't necessarily need the third plane unless it'll answer a specific question. You can try and cut down some of the sequences. It does take a lot of time. We usually don't do multi-plane on the pre-contrast. Maybe it'll only just be coronal T1. That'll give us a beautiful view of the abdomen. It'll show us the spine. It'll show us the spinal canal. It'll show us the kidneys if we're dealing with a Wilms tumor. And then we can go on to an axial T2 with fat saturation, again, using fast spin echo technique or turbo spin echo technique, depending on your vendor. And then we can go from there. And so we do try and tailor it and keep it limited. What we normally do when you say routine MRI sequence, we review our protocols every year, and we have discussions about the ones that seem to take a little bit longer time, especially the sedated patients. And so we go back and look to see where we can try and cut down on some of our sequencing. With some of the faster techniques, it still makes for a relatively short exam. I do like to follow with MRI for neuroblastoma. Again, it's not typically to the lungs. When I've seen neuroblastoma go to the lungs, it's usually in recurrence, poor pathologic prognosis. Again, a patient who's already been treated, who now is having a relapse and a complication. And so I'm not typically looking for lung nodules and metastases with CT. And so I like MRI and neuroblastoma together. Again, the age of the patient, you have to take into account the issue of sedation. With Wilms tumor, at our institution, we do a lot more CT imaging. And so that's why we're very careful about multiple phase acquisitions, which we do not do, and dose reduction technique. We're very, very careful about that and very cognizant of that, in part because we know that we can do all the imaging with Wilms with one exam. And number two is for some of the renal surgery, especially our pediatric surgeons like to look at CT. They find that a lot easier for them when they start to make their planning. But if all things were created equal, I like to do MRI for both if at all possible. When screening with ultrasound and Beckwith, what do you look for with regards to Wilms tumor? So we've seen multiple variations on the appearance of the kidney with just patients with Beckwith-Wiedemann syndrome. I've seen ones where they have multiple diffuse echogenic foci, they have some loss of cortical medullary differentiation, others that look more normal for age on ultrasound. I think what we're really looking for is any focal masses. And so I do recommend, especially in the younger patients, maximizing your technique using linear transducers, trying to maximize the frequency that you use, the focal point, the focal zone, the field of view, all of that, to try and best maximize your ability to pick up subtle masses. But really, we're looking just to see if there's any mass effect or any new changes to the kidney if we have a previous one. I don't know Dr. Hamad's question on the XP10 gene translocation and how does it apply to pediatric renal cell carcinoma. That's a great question. I'd have to look that one up. I don't know the answer to that one. I have been at Michigan for the past 3+ years after having practiced pediatric radiology in other places. And I personally can't remember the last time I've seen an RCC in a pediatric patient. It does occur, but I don't have enough experience with it. I would have to defer to my adult colleagues who see that tumor more often.
All right. Well, as we bring this to a close, I want to thank Dr. Bloom for this lecture, and thanks to all of you for participating in our noon conference. A reminder that this conference is available on demand on MRIonline.com in addition to all previous noon conferences. Be sure to join us on Friday for a lecture from Dr. Sheikh on MSK PET CT. You can register for that at MRI Online and follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again and have a great day.
Thank you.